So we'll talk about pediatric emergencies. This is a very broad topic. It's I just wondering, the scope, but I've tried to just bring it down to something that at least we will be able to appreciate, when we're talking about pediatric emergencies. And as an anesthetist and critical care physician, I felt we should talk more about some surgical and critical care pediatric emergencies, and that is what we'll be looking at in this lecture. So we need to, the learning outcomes include learning the early evaluation of the sick child. We need to we'll appreciate some of the common pediatric emergencies. I've included 10 of them in this lecture. And by so doing, we also learn the management of some of these common emergencies. All right, so by way of introduction, any child that is quiet should be presumed to be sick or otherwise. All right, a normal child should be active unless it's asleep, but if it's quiet, withdrawn, it should draw attention to something wrong. Trauma is the commonest cause of emergencies in childhood because they want to exploit, they want to touch, they want to drink, they want to do all sorts of things. So they're exposed to a lot of trauma emergencies. And early recognition, evaluation, and management of emergencies in childhood is important because it helps to forestall many preventable morbidities and mortalities. So the early evaluation of the sick child should begin with what we know as the pediatric assessment triangle. The pediatric assessment triangle includes looking at the appearance of a child in terms of tone, how does the child interact with you, the look and the speech of the child. The breathing pattern, this is important because the appearance and assessment of the work of breathing of a child can be used to determine the severity of the child's illness or injury. So you want to look at the child's breathing pattern. For instance, a normal appearance plus increased work of breathing is suggestive of respiratory distress, while abnormal appearance plus increased work of breathing may reflect respiratory failure. So looking at the child appearance and look at the breathing pattern can actually help to determine or evaluate the severity of the child's illness or injury. So you also want to look at the circulation, and we'll look at some of these things more in details as we go on in the course of the lecture. But suffice to note that a quick assessment of the sick child should begin with our pediatric assessment triangle. All right, so assessment of the child is just like the adult. You go to the ABCDE airway assessment. What you're trying to do is you're trying to look out for signs of airway obstruction, such as snoring, stridor, hoarse speech, some audible wheeze, or any signs of increased work of breathing, vis-a-vis nasal flaring, grunting, retractions, and paradoxical chest movement. And this is important. Part of the airway assessment is you want to determine if this patient or the child is able to maintain adequate ventilation and oxygenation with the correct positioning. Breathing, you want to assess the chest and abdomen for respiratory movement and evaluate the depth of breathing, the tidal volume, and the symmetry of movement with each breath. You want to evaluate the respiratory rate, all right, and to decide whether supplemental oxygen is required. You want to also look out for signs of hypoxia, such as the signs of hypoxia, dyspnea, stridor, or any signs of increased work of breathing. Importantly, you want to determine the SpO2 of this patient with a pulse oximeter. All right, the pulse rate, you want to assess the pulse rate. You want to look at the volume to determine adequate CVS function, tissue perfusion, and perfusion to all the vital organs. And some of these things you can actually do by determining your capillary refill time. All right, the capillary refill time that is more than 2 seconds may indicate low perfusion state. All right. You also want to look at the blood pressure, and the rough estimate of the minimal systolic blood pressure in a child is 70 plus twice the age of the child. So if the child is 4 years old, 2 times 4 is 8. So the minimal systolic blood pressure allowable for this child should be 78. All right, you want to assess for neurological fallout with your AVPU scale, and you want to also make use of your pediatric Glasgow Coma score, which is relatively different from the adult. Abnormality, okay, should also include level of consciousness, which may require immediate resuscitation and the tracheal intubation and ventilation as your assessment may dictate. It's important to expose the child. The child is small in nature, in build, so you want to expose the child, to reveal any area of burns, especially following trauma, bruising, fracture, or any evidence of other injuries. The secondary survey should focus on history from parents or guardian or caregiver. Let me state here that sometimes you may not get adequate and correct history from caregivers or from parents. There was a case we got it managed in ICU. The child was with a guardian, and the child suffered severe polytrauma. I'm sure Alam will remember that child. And the history we got was very deficient because there's some degree of cover-up. Sometimes, in terms of injuries, you want to also involve the social worker they have a technique of obtaining history and some collaterals from every other person that may be around the child. All right, exposure should include your ample history in terms of allergies, medications, past medical history, and all that. This should therefore be followed by a very detailed general and systemic examination. All right, so that's just an introduction and evaluation of the sick child. A quick evaluation is important, even though you're an anesthetist and you're given a consult to go see a patient, a child on your list. It's important to quickly assess. Like we know that sometimes our surgical colleagues may overlook some things. So it's important for you to have a general overview and evaluation of the child you're going to anesthetize. Now, common pediatric emergencies cover a range of conditions, which if we look at the systematically in terms of systems, cardiovascular, respiratory, GI, neurosurgical, or CNS. There are so many of them. So we're going to just pick some of the common ones. So first and foremost, a child who is in shock. All right, how do you approach a child who is in shock? You want to look at what is shock, which is acute failure of circulatory function with delivery of inadequate nutrients, all right? Delivery of inadequate nutrients to the tissues, all right? So you have low perfusion stage, and you want to determine what kind of shock this patient has, and my mnemonic is CASH, so you want to look at cardiogenic. Is the shock of cardiogenic origin? Is it anaphylactic? Is it septic or distributive, or is it hypovolemic? Because your management plans will be determined by the type of shock that this child is presenting with. You want to do a quick assessment. The skin is pale and mottled. A lot of times, pediatric patients in shock will present with tachycardic more than bradycardia. Once a child in shock is having bradycardia, it's an omeo sign. You want to look at the mental status of the child. Is a patient tachypneic? And decrease peripheral pulses, reduce urine output. This patient may be hypotensive and hypoglycemic. So the major thing is you want to identify the underlying cause and treat it. All right, fluid resuscitation. We talked about fluid management in our last lecture. All right, via large veins, we can also make use of vitreous routes and know that it depends on what is accessible to you at that point in time. But cases of sepsis or septic shock and all that, you want to employ your antibiotics following the sepsis guideline, hit hard, and get your blood cultures, and as much as possible de-escalate. Antibiotic stewardship is important. Steroids come to play, especially in terms of anaphylaxis, and even sometimes when you have refractory septic shock following your large doses of your inotrope of a suppressor, steroids may come to play here. So a lot of times, conditions of shock, especially hypovolemic shock, like your, bowel obstruction and what have you, some of these things will come across as we go on. But generally, you want to identify the underlying cause and treat it. The second common pediatric emergency is foreign body aspiration. Like I said, the child is very active, is explorative, he wants to, explore his environment, and by so doing, they could aspirate any kind of foreign body. All right. So foreign body aspiration actually could result in complete or partial airway obstruction, and is commoner in children less than 3 years, and is the commonest reason for bronchoscopy in the 1 to 3 year age group. All right, most small objects will lodge in the right main bronchus, and organic matters like peanuts could cause intense inflammatory reactions within few hours, and a lot of times, peanuts, for instance, can, for aspiration of peanuts can be very, very lethal because they induce severe, intense inflammatory reactions with leukoid pneumonitis, and sometimes it may be difficult, all right, to manage. Even after you've secured the airway, it's difficult sometimes because of the chemical inflammatory reactions that are taking place within the lung tissues. All right, history and evaluation, most times you will see these tripods of C's. The patient is coughing, trying to dislodge the foreign body, choking, inability to dislodge and causing either complete or partial airway obstruction, and the patient begins to turn blue, becomes cyanotic. All right, by the time the patient becomes cyanotic, you know that oxygenation has been impaired and something needs to be done as fast as possible to relieve the obstruction. Management, if you have time, you want to do a chest x-ray, most of the times it will show you lateral overinflation because of the obstruction, air trapping, all right, and rapid removal or immediate removal via regular bronchoscopy under GA, all right, is important. Is recommended that you have very experienced anesthesiologists to be present because airway management vis-a-vis oxygenation and ventilation is important. A lot of times, an experienced anesthesiologist may even see the foreign body in the oropharynx, all right, just during laryngoscopy, and the forceps may just do well to remove it. So you need to be careful, especially during pure oxygenation and manual bagging, manual ventilation, because a lot of times foreign bodies in the oropharynx or in the upper airway may be dislodged further down and makes removal difficult. Post-operatively, you want to do close monitoring of the vital signs, and steroids is very important that you give steroids because of edema and inflammation that has taken place, and you want to continue with humidified oxygen administration. And if in the case of organic matters that have been aspirated, like opioids, antibiotics, and in fact, admission to a high care at the least is recommended so that you could monitor this patient. Cases have been that so you successfully have removed the peanuts or the organic matters, but the patient continues to deteriorate in the ward, and the patient may die, not from airway obstruction now, but from the chemical or leukoid pneumonitis that the peanut aspirated generated. So it's important to have close monitoring, minimal in high care. And it's important also, part of the thing is you want to find out if you can obtain history. What is most likely, a lot of times the parents or guardian may be able to tell you that I think this patient or this child aspirated so and so. That will guide your management. Yeah, croup, acute laryngotracheobronchitis. All right, croup. All right, croup is a viral infection. All right, affecting primarily the upper airway, leading to swelling and narrowing of the airway. So it is an airway emergency. All right, it's characterized by a syndrome of inspiratory stridor, a backing cough, hoarseness, and respiratory distress. And the croup is usually of viral origin, the para-influenza. Symptoms of croup are usually of gradual onset. I need to take particular attention to this because you will need to differentiate between croup and epiglottitis as we go on. All right, symptoms of croup are usually of gradual onset and they are worse at night. Peak incidence, it occurs in children between the age of 6 months and 2 to 3 years. Lateral neck X-ray will help to exclude epiglottitis because the lateral X-ray will show the customary thumbprint appearance in epiglottitis, as we'll see on. The management of croup is usually supportive with humidified oxygen therapy. You want to give proper hydration to the patient. Nebulized steroids, the budesonide, 2 milligram is usually used, and also you want to nebulize with adrenaline, which also helps to relieve the airway swelling and obstruction. All right, so talking about epiglottitis, this epiglottitis is an acute life-threatening infection and inflammation of the epiglottis, all right, which usually is of a rapid onset, all right, and is associated with high-grade fever. Etiology is usually caused by Haemophilus influenza, although immunization against this bacteria has kind of reduced the incidence of epiglottitis, but it can also be caused by other bacteria like strep pneumonia and Staph aureus. Know that as against croup, it commonly presents at the age of 2 to 3 years. Signs and symptoms of epiglottitis, this is of a sudden onset and rapid progression, unlike croup where it is gradual onset, all right, and slow in progression. Here, there's fever with above 39 degrees Celsius. You have severe sore throat, which could lead to painful swallowing, causing drooling or saliva, and the child refuses to eat because of the pain. You have hoarseness or changes in voice quality. You can have difficulty with breathing, rapid breathing, stridor, and there's this tripod posturing where the child leans forward with the neck extended and chin thrust out, trying to clear the airway to make room for the airway. Note that the absence of a cough or backing cough distinguishes it from croup. However, management is supportive like croup, but you want to obtain an X-ray, a lateral soft tissue neck radiography, which will reveal characteristic thumbprint sign. All right, the thumbprint sign indicates swollen epiglottis. All right, it's a bacterial infection, unlike croup, which is more of a viral thing. So antibiotics are frozen 50 milligram BD per kilogram BD. A lot of times, endotracheal intubation is called for. And listen, this is important. I've had cases of epiglottitis. Once you know that this patient has epiglottitis, you don't want to risk trying to intubate this patient on your own. The best hand should be on board. And a lot of times, endotracheal intubation will be difficult and sometimes fails. So we always request for the ENT specialist to be on ground for emergency tracheostomy should you lose the airway in an attempt to intubate. So epiglottitis is not a child's play. It's something that you need to take seriously, especially if you need to take over the airway. An ENT surgeon scrubbed. Now I'm emphasizing this. All right, you're going to be specialist. You should insist that I've got a child, 2-year-old child with suspected epiglottitis, and one of the ENT surgeons scrubbed in theater with the tracheostomy tray ready to be opened. Should you have difficulty in accessing or, uh, putting a tube and the sugar tube, the ENT surgeon should rapidly gain the surgical airway. Or if that phase is most likely, the patient will be lost to airway loss. So it's important, especially for epiglottitis. And this is a common question I like to ask. So I'm saying this, what are your airway management plans for a 2 or 3-year-old child with a suspected case of epiglottitis? All right, this is what I want to hear. You want to nebulize with oxygen, you want to hydrate, you want to, nebulize steroids, but more importantly, you want to secure the airway with the ENT surgeon in attendance. I hope I've made that clear. All right, so let's move on. A lot of times you may want to, ask you to differentiate between croup and epiglottitis, and what are the criteria for admitting a patient with croup. The next one is asthma. All right, we know what asthma is, so we're going to go through it. Signs of life-threatening asthma: silent chest, patient is cyanotic, poor respiratory effort, and the patient may lose consciousness. So your diagnosis of an asthma in a child, you want to look at history of recurrent respiratory symptoms, and you want to look at the triggers. Sometimes they may tell you that the child has difficulty with breathing when he goes to play on the grass or with the flowers or with pets. So these are history that may suggest a case of asthma. All right, physical examination, you want to assess lung function, presence of wheezing, and signs of respiratory distress. These are things that happen earlier on, but don't forget that when it becomes severe and life-threatening, you can have a silent chest. You won't pick anything on auscultation. Pulmonary function test, your spirometry and peak flow meter comes handy. All right, and when you want to look at the peak expiratory flow rate and all that, allergy testing is important to know what this child is reacting to. Management, nebulized salbutamol, steroids, aminophylline, these are things that you can use. And sometimes when you have a non-asthmatic child who is presenting for surgery, you need to follow the guidelines, even as for adults. But it's important for you to pick it up, during the preoperative assessment. All right, so there are different ways to assess severity of asthma. Like I mentioned, we have some 4 signs of life-threatening asthma: silent chest, poor respiratory effort, loss of consciousness, and all that. So you want to look at the patient's consciousness. Is the patient conscious, all right, or unconscious? You want to look at exhaustion. Is the patient exhausted? Is there cyanosis? Wheezing. In life-threatening cases, you will hear wheezing. Respiratory muscle retraction, use of accessory muscle, and your peak expiratory flow rate is usually less than the 3% in life-threatening severe asthma. You want to look at the saturation in room air, will give you less than 92% for life-threatening severe asthma. So this is a way of evaluating, all right, the severity of asthma. All right, we go to neurological pediatric emergencies, and what the first one here, we're looking at meningitis. All right, meningitis could be of viral, bacterial, or fungi. It could TB meningitis. All right, usually the meningitis of viral origin usually are due to Coxsackie mob viruses, while bacterial meningitis can be due to Neisseria meningitis, strep pneumonia, or Haemophilus influenza. All right, we can have aseptic meningitis, which may actually be caused by malignant infiltration into the meninges, chemical irritation, especially use alcohol rub during lumbar puncture. Signs and symptoms of a meningitis will include fever, all right, together with nausea and vomiting, headaches, photophobia, and you can have convulsions, and the patient may actually tip into coma. All right, on examination, you can notice neck stiffness or neck pain, and you will have sometimes positive canine signs. Diagnosis is from lumbar puncture, all right, to obtain CSF for analysis, and which includes cell counts, puncture, and biochemical markers in the CSF. Blood test is important. Imaging, blood tests like full blood counts and all that may give you evidence of infection, all right? Imaging such as CT, MRI, and other investigations that may be required will be determined by the underlying cause and the patient's clinical status. Management should want to look at the CSF analysis to be able to differentiate between bacterial and viral causes of meningitis. All right, when you have increased lymphocytes, raised protein, but normal glucose, you know that this meningitis is most likely of a viral origin. But meningitis of bacterial origin will have increased polymorphs and protein, but reduced glucose. In aseptic cases, you have increased multiforms, but normal glucose. So it's important for you to obtain your CSF and do a proper analysis. Most of the times, bacterial meningitis responds to ceftriaxone, and in fact, you need to start before you don't wait for the results of your culture sensitivity. And the steroids are 0.15 milligram per kg 6 hourly usually indicated because it's an inflammation of the meninges. Status epilepticus, common in children, especially, it's characterized by epileptic seizure that is frequently repeated or so prolonged as to create a fixed and lasting condition. All right. Or it can also be defined as a continuous seizure activity or recurrent seizure activity without regain of consciousness lasting more than 5 minutes. All right, refractory status epilepticus refers to an epileptic fit that fails to respond to treatment, usually with at least 2 medications such as benzodiazepine and any other anti-epileptic agent. All right, so status in case once you're able to identify that this patient is in status epilepticus, you want to immediately start your ABC line of resuscitation with oxygen therapy. All right, you want to ensure the airway is patent. You want to ensure that patient is breathing and circulation. And supplemental oxygen is actually very important because it helps prevent, hypoxic brain injury or even, hypoxic injury to the vital organs. So you want to do some investigations, blood glucose and urea, because all of these can actually precipitate a seizure episode. Like mnemonic, so definitive management, you put the patient in a bag, all right, your benzodiazepine to abort the seizure, your anti-epileptic or your anticonvulsant like phenytoin, sodium valproate, your Levity, what's that one? Kypra, all right, and you want to induce a general anesthesia with your propofol or midazolam to ensure you reduce global cerebral work and oxygen demand. Febrile convulsions, yes, febrile convulsions usually occur in children aged 6 months to 6 years, and usually are children with a high fever. All right, it's like I said, it's common among children between 6 months to 6 years, and it affects approximately 2 to 5% of children. All right, etiology and risk factor fever is the trigger. All right, most of the times the temperature is above 38 degrees Celsius. All right, family history. All right, if positive family history increases the chances of a child having febrile convulsion. All right, symptoms and characteristics of the seizure is generalized seizure activity, associated with loss of consciousness. It can have rhythmic movement and shaking of the limbs. It can actually come with altered breathing pattern, and the patient may actually have periods of apnea, stiffening and arcing of the back. So care management is usually very supportive. You want to ensure a safe environment for this child, especially during the convulsive fits. You want to position the child laterally to prevent choking, all right? And you want to time the duration of the seizure. And don't forget that you need to also look at the underlying cause, all right? In tropic region like Nigeria and all the tropic area, you want to make sure that this patient does not have malaria. All right, malaria fever is a common cause of febrile convulsion in tropic region. You want to look at the, other sources of infection like pneumonia, for instance. All this, anything, any kind of infection can actually predispose to febrile convulsion. So you want to also ensure that you want to treat the underlying cause and bring fever down. Fever is a trigger. So you want to bring fever down pharmacologically and not pharmacologically. So these are important measures that must be taken. You must cool this child by all means because the convulsion is triggered by fever. Yeah, GI emergencies picked up 2 intussusception. I'm sure we've anesthetized children with intussusception before. All right, we know that it is the telescoping of one portion of the intestine into an adjacent segment. The etiology is not known, but it can be triggered by different factors such as viral infection, lymph node enlargement, or it could be due to structural abnormalities in the intestine. It has a classical triad of symptoms: colic, abdominal pain, CVC. All right, if you like pneumonic, CVC, colic, abdominal pain, vomiting, which is often bilious, and you have current jelly-like stools. Diagnosis is usually taken from history taken, which includes onset and duration of symptoms, a physical examination to assess for abdominal tenderness, palpable mass, and you may also want to look out for signs of dehydration and shock. Abdominal ultrasound can actually localize or locate the portion of the intestine that has invaginated into the adjacent intestine. Constant enema also helps. All right. Management could either be non-surgical or surgical. Non-surgical reduction of intussusception is indicated when there are no evidences of bowel perforation or peritonitis. Surgical intervention actually aims to reduce the intussusception, remove any compromised or damaged or non-viable intestine, and restore normal blood flow. Don't forget that this is generic. You need to also look at your fluid and electrolyte balance, look at the general well-being of the child, and ensure that if the child comes to you for anesthesia, you want to do your normal pediatric anesthetic considerations for this patient. So it's important for us to know that these patients with intussusception can come to you as an emergency. The last common pediatric emergency we're looking at this evening is bowel obstruction. All right, which intussusception can actually be a cause. Other common causes of bowel obstruction in children include congenital abnormalities, all right, hernias, all right, others like adhesions, tumors, or foreign body impaction, or foreign body injection, which can impact the bowels, may lead to bowel obstruction. All right, signs and symptoms include abdominal pain and distension, vomiting. I like using the word PCV, all right, pain, vomiting, and constipation. Also look out for signs of dehydration and electrolyte imbalances. History taking is important. Physical examination, imaging studies with abdominal X-ray, which will show you evidence of bowel obstruction, all right? Abdominal ultrasound and CT scan. So management includes initial stabilization. You want to obtain vital signs and ensure you continue to monitor. You want to monitor the fluid status and electrolyte imbalances. NG tube insertion is usually indicated to decompress the stomach and relieve the vomiting. We could have two kinds of intervention, not surgical reduction or intervention, or you can have surgical intervention, which may be necessary to remove obstructions, repair hernias, and address other causes of bowel obstruction. Oh, thank you, ladies and gentlemen. This is just a run through about the 10 common pediatric emergencies that are very important to us as anesthetist and critical care physician. There are other emergencies that are not covered, but following the normal evaluation of the sick child, following these other outlines or guidelines of pediatric management will help, especially dealing with, some of these pediatric common emergencies. So thank you. If you have questions, we can go ahead.